Yo intentaré mezclar inglés con español como pueda. Bueno, buenos días a todos. Bienvenidos a este webinar de la SILACO. Vamos a hablar del tratamiento quirúrgico de la escoliosis idiopática del adolescente. Tenemos un panel, un invitado internacional de primera línea. Pasa al siguiente, por favor, Ana. It's a great pleasure and honor to have Dr. Lenke with us. Dr. Lenke is a global top spinal deformity surgeon and international leadership guru. He is well known to you all. Needs no introduction. Thank you, Dr. Lenke, and welcome to this webinar as a guest international speaker to SILACO. Also, siguiente, we have a great panel, Dr. Juan Carlos Bernasconi, President of the Argentinian Spine Society. As a panelist, siguiente, we have Dr. Cristiano Meneses, Vice President of Brazilian Spine Society. Siguiente, Carlos Montero de Colombia, past president of Colombian Spine Society. Siguiente. Rafael González is secretary of SILACO and past president of HER, Spanish Spine Society. Dr. Armando Pineda, welcome for the first time from Venezuela. Welcome, Venezuela. He's the vice president of the Venezuela Spine Society. Siguiente. Baron Zárate, president of AMSICO, Asociación Mexicana de Cirugía de Columna. Yo soy Hani Maidli, intentaré coordinar un poco el tema, soy presidente de SILACO. So welcome, Dr. Lenke, and we start the lecture.
Thank you, Hani, appreciate it. Good morning, everyone. Welcome, everyone. Thanks for joining us on this morning discussion of AIS. All right, can everyone see my slides okay?
Yeah, perfect.
Good, great. So again, we're going to talk about surgical management of AIS. Here are my disclosures. So we'll start by just reintroducing, hopefully, the well-known classification system, the triad system of curve type, lumbar spine modifier, and sagittal thoracic modifier. Again, I still use this system to help categorize patients into the various patterns, and also then select the various treatments options that we have. We do use a third modifier. You'll see this through my talk, and that's the touched vertebra modifier that we've been popularizing. That is, again, the last vertebra touched by the center sacral vertebral line on the standing AP X-ray. Here, that's L2. And that is often, not always, but that often directs us to what the appropriate lowest instrumented vertebra should be. As you see here, we selected L2 for this AIS curve pattern, and 5 years post-op, it has perfect alignment, both of the instrumented and, importantly, uninstrumented spine below. The treatment directions are still the same. Single curves, either type 1, main thoracic, or type 5, thoracolumbar and lumbar, can be treated with either posterior or anterior techniques, but double, triple curves are treated posteriorly typically today with segmental pedicle screw fixation throughout the world. So we'll begin with the most common curve type that we see. 20% of curves are type 1AN. Here's a 70-degree thoracic 1AN curve. So again, the touched vertebra here is L1. So we classify 1AN/L1. And we treat this with a posterior instrumented fusion down to L1. And that means that we treated it to the LIB. So the parentheses 0 means that the touched vertebra was L1 and the LIB is L1. So that's a 0 ending construct with very good alignment here at 3 years postoperatively and the clinical photos. Here is another very common pattern, a double thoracic, type 2A+, a bit of hyperkyphosis in the thoracic spine. The touched vertebra is L2, so the complete curve classification is 2A plus L2. And here we do a T2 to L2 0 treatment. So we stop the LIB is the same as touched vertebra. with very nice radiographic results at 2 years post-op and clinical results as well. Here's a very large double major curve. Highlight several things here. Number one is that this is a 3C plus L4 curve type. And again, a very large and fairly stiff curve, but we still treat this with posterior-only techniques with just posterior osteotomies, posterior column or ponte osteotomies. You see here we do go down to L4. L3 is just too rotated and too far off the center line with this long construct with acceptable radiographic results for this large double major curve. Very common curve pattern is an isolated thoracolumbar or lumbar curve. Here, the 62-degree 5cn L4 curve. You see L4 is the lowest touched vertebra. And then the question on this is, do we stop at L3 versus L4? Very controversial. The L3-4 disc is parallel. But for me, when the apex is L1 on this type of curve and on the right side bender, L3 does horizontalize fairly well. I elect to stop at L3. So we do a short T11 to L3 procedure. This is a -1 fixation because the touch vertebra is L4, LIV is L3. So we save one level versus the touch vertebra rule. And we have very nice radiographic results here at 2 years postoperatively and the clinical results. And lastly, for a complete spectrum, here's a type 6 double major curve where the major curve is the lumbar curve, 65-degree thoracic, 74-degree lumbar. Touch vertebra is L4. So this is a 6cn L4 curve pattern. And I elect to stop at L3. So here we do a T4 to L3. This is a -1 fixation. You see we have fairly good centering and horizontalization of L3, maybe a little rotational difference between L3 and L4. So this is, again, controversial, but the sagittal plane alignment is perfect. So hopefully this will last a long time with this L3 fixation. So that's kind of a recap, kind of where we've been and how we've been doing things. So what has changed the past 20 years since this classification system came up and since we basically started using pedicle screws? We look at the spine for optimal 3D correction. You see, I'll show that I use often a supine x-ray instead of side bending x-rays to determine my minor curve structurality. We really still believe in selective thoracic fusion, so I'll talk about that briefly. Obviously, posterior VCR for only very select severe rigid curves. We don't use this often in AIS, but I'll show a primary and a revision case when I think it's indicated. And obviously, there's a lot of interest in vertebral body tethering. I'm not going to cover that much. I'll show one case, but it's unsure in mature AIS where that's going to lead to. Maybe that'll be part of our discussion panel. But I like not to spend a lot of time on that for a variety of reasons. But that isn't going to be a very interesting topic of where we head in the future for AIS treatment. So just to show how we use the supine x-rays to help determine classification and treatment, here's a 6C minus L4 curve. The middle x-ray is just a single supine image. We get this on all patients, adults and children. And we're now determining criteria comparing the supine image to the side bending when we can basically, through one x-ray, determine what the structural minor curve criteria are. Here it's pretty obvious that the 60-degree minor thoracic curve is structural. It only changes to 57 degrees going supine. There's also very severe thoracolumbar kyphosis between the two curves. So we have to treat this as a double major curve. We cannot do a selective lumbar fusion on the major 80-degree lumbar curve. And that's what we do here, 2 years post-op. Very nice radiographic results with a nice three-dimensional correction of both curves, seen also by the clinical photos as well. Also highlighting how we really try to perform optimal 3D correction of thoracic curves. Here's a 1A minus L2 radiographic presentation of this teenager with AIS. So we do a very standard T4 to L2 instrumentation and fusion. And we want to highlight the nice instrumented three-dimensional correction. The screw alignment is quite good on the AP view. You see the overlapping rods in the sagittal plane with very nice kyphosis production. But I want to highlight also is not only the change in the instrumented spine, which we can control obviously, but the marked improvement in the uninstrumented spine. You see the cervical lordosis above and the lumbar lordosis below on the 2-year total body x-rays shows remarkable realignment of the spine. And we've just published this recently, reciprocal change in sagittal profiles after AIS surgery with segmental pedicle screw constructs through this total body analysis. Again, this is our goal, is not only to optimize the instrumented correction, but also optimize the non-instrumented spontaneous correction of the spine. And this is true for any patient, whether they have AIS or other pediatric or adult deformities. We're really looking into, obviously, the uninstrumented spine realignment as well. So what about selective thoracic fusion? When can we leave the lumbar curve unfused? Obviously, it's recommended by the CIST classification system that for 1C and 2C curves that we do this, but what about even 3C and 4C curves? Are there opportunities for just doing selective thoracic fusion in those curve patterns as well? So here's a very common curve pattern, 74-degree thoracic, 56-degree lumbar, 1CN T12. Since the lumbar curve is flexible, it corrects to 22-degree on side bending. It's a minor non-structural curve, hence the 1CN classification. Here's where we use these radiographic Cob ratios that we published after winning the Hibbs Award at SRS in the early 90s, almost 30 years ago. We still use these ratios. Again, the Cob ratio, the AVT, apical vertebral translation ratio, and the AVR ratio. Again, when these ratios are greater than 1.2, it's favorable for selective thoracic fusion, with the most important ratio being the AVT ratio. And especially when that's close to 2 or over 2, that's very favorable for a selective thoracic fusion. We also here look at the supine image in the middle and even a push-prone simulated thoracic correction. You see how we very nicely not only see the thoracic spine slightly improve, but the lumbar spine also improve as well, just spontaneously on the supine image and with forced correction. So this gives us also confidence that we can do a successful selective thoracic fusion. Also looking at the patient, we see again the thoracic deformity and the scoliometer measurement is greater in the thoracic region than lumbar region, also promoting the use of selective thoracic fusion. So here we did a T40 T12 selective thoracic fusion. You see 2 years post-op, we have very nice radiographic alignment of the instrumented and excellent spontaneous lumbar correction from a C to an A modifier, with nice derotation spontaneously as well, with the nice production of better thoracic kyphosis in addition. And here's the clinical exam. And importantly, SRS scores, what we see very commonly in AIS and even selective thoracic fusion, marked improvement in the self-image domain from 3.3 to 4.8, and the satisfaction domain overall from 3.0 to 5.0. So a very satisfied patient following this selective thoracic fusion. And Keith Bridwell and I published a long time ago our results selective thoracic fusion with proper identification of the patients to undergo selective fusion and proper instrumented techniques in 44 consecutive patients. We had no reoperations in any of these patients and very satisfactory results. So again, you have to both properly identify and treat these patients to have a very nice result with saving the lumbar spine for motion in later life. What about this type of curve? Classification 3CN-L4. So L4 is the lowest touch vertebra since the lumbar curve is structural. It only bends to 32 degrees on the side bending. So again, the classification recommends that you do a double major construct here. But again, can we do a selective thoracic fusion? We have to always ask ourselves that question. Well, let's look at the radiographic ratios. Again, Cob ratio 1.33, but the AVT is again 2.0, 6 centimeters over 3 centimeters. Very suggestive of a selective thoracic fusion. Clinical exam, again, prominent right scapula, excuse me, slight indentation of the lumbar waistline asymmetry. But again, scoliometer measurements, 17-degree thoracic, 12-degree lumbar. So very favorable for selective thoracic fusion. So here we do a T40 T12 fusion. Since the lowest touch vertebra of the structural curve was L4, this is a -4 fusion. We saved 4 lumbar levels by doing the selective thoracic fusion. Here with excellent both coronal and sagittal alignment at 1 year postoperative. And this was especially important in this patient as she not only has good cosmesis, but is a very active swimmer. She actually is a state champion swimmer, and 3 months postoperative, she came in 2nd place in her state championships and went on to Harvard University to swim competitively in college for all 4 years. So again, the importance of saving her lumbar spine and doing a selective thoracic fusion was especially important in this athlete. One question that came up always is how much correction do we get of not only the curve, but of the lowest instrumented vertebra? Dave Skaggs, Mike Vitale, and I looked at this in more detail, and we found that patients with less LIV tilt post-op, so more horizontalization, had better overall lumbar curve spontaneous correction and spinal balance. So we are pretty aggressive with 1C and 2C cases to horizontalize the LIV, but I must state that we do proceed with caution on larger and stiffer lumbar curves, those with 3C and 4C, to make sure we have a good accommodation of the unfused curve below. This is the art of doing selective thoracic fusion. It is something you have to pay attention to. I get intraoperative x-rays to look at the balance after the correction to make sure that the thoracic correction above is balanced with the unfused lumbar curve below. I think that's very important. Lastly, what about vertebral column resection? Obviously something that's I'm well familiar with. I've been done over 325 of these now in the last 20 years, and also published a fair bit on this to try and make this very challenging and dangerous surgery much more safe in not only my hands, but everyone's hands. This was the first posterior VCR that I did, and I published it. It was in 2000. A girl who came from Moscow, Russia through the Shriner system, had a very severe life-threatening curve with cor pulmonale. So I did halo gravity traction and a 2-stage, 2-level posterior VCR. You see the radiographic results above and the clinical results below. In this case, changed my practice. From then on, I did not do any more anterior release surgery, which was my tendency. That was my history in the 1990s before I did this case in 2000. And after this, I've not done any anterior release for any patient, adult or pediatric, in 20 years. So we decide on VCR based on several things, including angularity of the spine. So we popularized the deformity angular ratio. Again, the Cob measurement, 159 over the number of vertebra making up the Cob, here 8. So DAR of 19. With higher DARs of 10 in the coronal plane, 15 in the sagittal plane, or total DAR greater than 25, we have increased spinal cord monitoring alerts and new neurologic deficits. So those are more dangerous surgeries, obviously. And here's where the benefit of doing a VCR, where we shorten the apex by taking the apical vertebra out and then shorten the apex, allows us more freedom and less neural tension to be able to have a more successful surgery. We've also recently now published and promoted the spinal cord shape classification system, or SCSCS. Here we have 3 types. Type 1 is where there's CSF circumferential around the spinal cord at the apex. Type 2 is where there's no CSF at the apex. The spinal cord is touching the pedicle, body, or lamina. And type 3 is where the spinal cord is actually deformed at the apex. Not surprisingly, the odds ratio of having spinal cord data loss is much higher when you have a type 3 spinal cord at the apex. This does correlate, but not perfectly, with the DAR, but it just shows higher neural tension before you start your scoliosis surgery. So these are cases, type 3, that were more likely to do either apical pedicle excision or complete VCR for neurologic safety. So a primary case, here's a 138-degree AIS curve in a 16-year-old. Coronal DAR is 17, so it's a pretty high DAR. There's a little bit of kyphosis as well. So his classification is 4A plus L4, 3 structural curves here. So we do a T2 to L4 instrumentation and fusion with here, you see a single level T10 BCR. Here's 5-year radiographic results, very nice realignment. And I want to highlight the excellent clinical results. There's no thoracoplasty done here. This is all just correction from the single level VCR and instrumentation and fusion. In revision case, where I think a VCR is indicated, here's a juvenile idiopathic that at age 12 underwent anterior and posterior fusion at another institution with a hook construct. Here are the early results at age 12. You see the 2 scars from the anterior release and the posterior fusion. When she showed up to me at age 20, you see she had severe progression of her deformity. Her implants have been taken out because of prominence. She had 5 surgeries ultimately and has a severe coronal and sagittal plane deformity with increased shortness of breath and pain. Her 3D CT scan shows severe rotational malalignment and a solid anterior and posterior fusion of her spine at the apex. So again, I think in my hands and probably many others, the best way to treat this is with a posterior-based VCR. Here I do a 2-level VCR for both coronal and sagittal realignment of this patient as a salvage procedure in a long construct. Here's the postoperative clinical photos as well. And lastly, it's been known now quite nicely in this even early report of mine that in juvenile and young adolescents, we can have very excellent growth modulation with vertebral body tethering. Here's a 5-year result. You see where actually the curve is going the other way. We have actually reverse scoliosis. We had to actually cut the tether on this patient because of progressive reversing of the scoliosis. You know, where this plays a role in mature AIS, I'm not quite sure yet. Again, I'd like to discuss that. But in my hands, I'm not using this for mature adolescents, only in very immature juveniles or AIS patients. So in conclusion, the LINQ EIS system has remained relevant over 20 years due to its comprehensive yet modular method of radiographic curve depiction with treatment guidelines, and along now with the use of the touch vertebra as the third modifier to aid in LIV selection. Optimal 3D techniques are now standard of care, not only for the instrumented spine, but trying to optimize the uninstrumented spine above and below. Selective thoracic fusion should be considered for appropriate AIS patients. Posterior BCR is reserved for our most severe angular, primary, or revision AIS patients. And as I mentioned, to me, it's unclear as to what role the current AIS classification system will play in the use of vertebral body tethering in AIS patients, and to what extent the role of this non-fusion technology will have long-term. I thank you for your attention.
Thank you, Dr. Lenke. Excellent presentation, Dr. Sarate. Now it's your turn to control the questions from the panel.
Thank you, Dr. Hani. Thank you very much, Dr. Lenke, for a great lecture. I just want to ask, before I ask the panelists, about the sagittal stable vertebra. Dr. Lenke, can you tell us a little bit about this?
Great. That's a great point, Baron. And actually, we coming in November is our 5-year publication on using the coronal touch vertebra for LIV selection. I used the Harm Study Group database for that. And interestingly, before they would accept it for publication, they made us go back and measure the stable sagittal vertebra on all 310 x-rays. And I personally had to do that. It was a lot of work. But you bring up an excellent point. Thank you. Because on every case, we need to not only draw the center sacrovertical line on the coronal x-ray, but we draw the posterior sacrovertical line on the sagittal x-ray. And if the last touch vertebra in the sagittal plane is more distal than the coronal plane, we have to be very careful with going to the coronal touch vertebra. Sometimes we have to go more distal. So whichever one is more distal is usually the safer LIV to select. Interestingly, in our review of this cases, and these were only type 1 and type 2 main thoracic, double thoracic curves that we reviewed, only in a handful of cases, I think 5 or 6 cases out of the over 300, was the sagittal stable vertebra made us change to a more distal LIV. So it's very unusual that happens, but it does happen. And so you must pay attention to that. And now what we do is we do draw the posterior sacrovertical line on all our cases, as well as the center sacrovertical line to make sure that we're looking at both, because you don't want to miss that malalignment in the sagittal plane. And normally that also goes along with a thoracolumbar kyphosis, is the most common pathology. So normally we pick that up also if we just look carefully from T10 to L2. You'll have kyphosis there, and that will mean that you have to go more distal, and that often means that you cannot do a selective thoracic fusion, as I highlighted. You have to do the lumbar curve of a 1C, 2C, 3C, or 4C.
Thank you very much, Dr. Lenke. I want to, Dr. Bernasconi from Argentina. Dr. Juan Pablo, can you give us a question to Dr.
Yes,
Lenke?
I have a couple of questions. The first is which is actually the place of the ponte osteotomy, Dr. Lenke, for you?
Right. Yeah, I didn't mention this, very common. So if I'm trying to restore better thoracic kyphosis, to me, I'm doing ponte osteotomies over 3, 4, 5 levels at the very apex, the very lordotic apex. After we expose the spine, almost all AIS patients have a bit of a lordotic apex or hypokyphotic apex. So I do not hesitate to do ponte osteotomies. I think they're very safe. They're they're not much bleeding associated with them. So I'm very aggressive with that. And also in larger curves, any coronal curve over 70, 80 degrees, I'm very, very aggressive doing multi-level ponte osteotomies to help with curve correction.
Actually.
Yes, so very commonly.
Okay. And the other question is about the selective thoracic fusion in the C modifier. What's your opinion about the amount of corrections first and the implant density?
Right. So the amount of correction, as I mentioned in the one publication, I'm much more aggressive now with the amount of correction I do, especially with 1C and 2C curves, because as we showed in that study that I highlighted, correction in LIV horizontalization, not leaving tilt but horizontalizing it, does seem to give better spontaneous lumbar correction for 1C and 2C. But when you do selective fusion for 3C and 4C, with more structural lumbar curves, I still think you have to be a little careful to leave a little more residual thoracic curve and a little more tilt to the LIV to accommodate the lumbar curve below. So again, to me, that's the artistry, the art of selective thoracic fusion. There's not one size fits all. So you have to be very careful. I think you have to look at the pre-op x-rays very carefully. You have to look at intraoperative x-rays carefully and decide that.
No, yeah, the question is especially for seems like is more important the balance.
Right, exactly. That's why.
And the rate of correction. No?
That is correct. I think if you are too aggressive with overcorrecting, especially a 3C or 4C selective thoracic fusion, you do risk decompensation. And even in some 1Cs, you do risk the early decompensation of the spine. Now, normally that will improve over time, but if you've made the spine completely straight, thoracic region, that's usually not a good prognosis. You have to almost always leave a little curve. If you saw my cases, I never made the spine completely straight as we do in 1A or 2A, right? I leave always a little bit of under correction, and then I leave a little tilt to the LIV. And I leave more if the lumbar curve is stiffer. That's basically simple. As far as implant density, I mean, we've had this discussion for 20 years now. I'm not sure, but as I highlighted in that swimmer, 3 weeks post-op, she was already swimming in a pool after her wound was healed, and had no issues because
that is just possible only with high density.
Well, I don't know that, but I don't want to find out. I mean, to me, I don't want to find out that because I didn't use enough screws, that you get a little screw loosening on top or bottom. Occasionally we see that in some of my revisions I've had to do in other surgeons. I mean, it's very uncommon, obviously, in AIS. But to me, my goal is 0 complications, short or long term. Actually, I didn't highlight this because we're submitting this. We just put an abstract together. Since I've been in New York since 2015, I have 84 consecutive AIS patients that I've treated. I've only had 1 complication in any of those patients. At 1 year post-op, I have 1 pseudarthrosis at L3-4 in a very large male that I did a T3 to L4 fusion on. So he just got a revision a couple months ago. Otherwise, 0 reoperations, 0 readmissions, no short-term, long-term other complications. So again, my goal, the title of my talk is how close are we to complication-free AIS fusion surgery? And I say fusion surgery because, again, in contradistinction, in colleagues that do tethering for AIS, they have a much higher complication rate right now. Now, again, that's going to decrease over time, right, as people get better at it. But in my hands, it's very hard to beat a selective thoracic fusion. I'm not sure, when now we average a 2-day hospital stay, we have unlimited motion as far as above and below, and you see the sport activity, patients can do whatever they want, and they're very active without restriction. That's a high bar to meet, right, for a tether when you have to go through the chest, even if it's endoscopically. If my daughter has a 65-degree thoracic curve at age 15, she's getting a selective thoracic fusion right now in 2020. She's not getting a tether. I'd like to hear other panelists' opinion, because I think that's very controversial right now around the world.
Yes. Thank you, Darryl.
Thank you, Dr. Bernasconi. Dr. Lenke, we have a question from the audience. Dr. Juan Jara wants to know about when you have a case with escoliosis and spondylolisthesis at the same time, how do you treat that? Thank you, Dr.
Yeah, so there's 3 scenarios. One, the scoliosis is definitely the bigger problem. It's a bigger curve. They're immature, and so we need to definitely treat the scoliosis. Or sometimes, they have a smaller scoliosis and a higher grade spondylolisthesis with some tight hamstrings, some neural tightness, L5 symptoms. Then we treat the spondylolisthesis first. Sometimes they come in with both a high grade spondy and a large curve, and we have to treat both. And it depends on the symptoms. Again, if it's an asymptomatic spondy, I almost always treat the scoliosis first. The big question is, if they have a large double curve, do we have to go to L4? Can we go to L3 to stay away from the spondy? These are all very, very important decisions, and they are very individualized. But as you know, around 7% of patients that have idiopathic adolescent scoliosis will have some form of spondylolysis or spondylolisthesis. So we have to always look for that on the sagittal X-ray. Usually it's low grade, very, very minimal, and it doesn't play into our treatment of AIS. But sometimes, it does play a role, and we have to understand that and plan treatment of it. The key is that don't ever miss that. Always look carefully at the lumbosacral region on all your X-rays, including AIS, to make sure you don't miss that. And always ask the patient if they have any lower back pain, because as you know, sometimes they may have much thoracic back pain, but they may have some subtle lower back pain from a very small low-grade spondylolisthesis. So we must always ask the patient that question.
Thank you, Dr. Lenke. Dr. Carlos Montero from Colombia, can you tell us something, please? Can you give us your question? Thank you.
Gracias, doctor Zárate. Doctor Lenke, uno de los problemas frecuentes con las curvas Lenke 5 es la descompensación. Casi siempre esas curvas son severas y descompensadas. ¿Usted tiene en cuenta la descompensación para mirar los niveles de fusión? ¿Sube un nivel más o baja un nivel más si están descompensadas?
That's a good question. So if the major curve is the lumbar curve, often they are kind of shifted to the convexity. So there's where I like to use the supine AP pre-op image to help me sort out what's happening. Because if they're decompensated standing, but when they lay down supine, they get compensated, then I'm more likely to treat them in a very standard fashion. Almost always the lowest instrumented vertebra is going to be the lower end vertebra, not the touch vertebra. And I showed that in one of the cases where I stopped at L3, not L4. But if they are persistently decompensated, even on the supine image, then I'm more likely to go to L4. So that's how I decide that. But it really is often an L3 versus L4 decision for the LIV. For the UIV, if I'm doing a selective lumbar fusion, I like to do symmetry. So wherever my apex is, I do equal levels of fusion above and below. So if I do 3 levels of fusion below, I'll do 3 above the apex, whether the apex is a disc or vertebra. So I like symmetry about the apex. And then the key is, do you stop at L3 or L4? Very rarely you can stop at L2 in a thoracolumbar curve. It's almost always L3 versus L4. But I use the supine image to help decide whether that decompensation is structural or non-structural.
Gracias. Thank you, Dr. Montero. Thank you, Dr. Lenke. Dr. Lenke, we have another question from the audience. Dr. Armando Pineda wants to know, how do you select your spinal fusion levels in Lenke 5 curves? And with that, another question from him is, when do you ask for an MRI?
Sure. I'll answer the second question first. When do I ask for MRI? The answer is always. Any patient that I'm doing adult or pediatric spinal deformity surgery on, I get a total spine MRI from the brain to the sacrum, from the base of the brain to the sacrum. Why do I do that? Number one, because as I've shown now, this spinal cord shape classification system is real. And I can tell you that I've seen some 60-degree AIS curves, very straightforward. Some of the easiest things that I do in my practice have a type 3 spinal cord at the apex, or at least a type 2 and a type 3, where the spinal cord, even in a very moderate 60, 65-degree AIS curve, the spinal cord is already fairly tight against the apex. And I've also had, I can tell you, loss of spinal cord data correcting those patients. Now, they've recovered by taking some correction off, we're doing monitoring, but there's a disconnect between the angularity and severity of the curve and the shape of the spinal cord at the apex often. So that's why I always want to see exactly what that apex is, because I want to be prepared mentally and from a planning perspective, what I'm going to do to this case. I can tell you that occasionally, we have to do some more convex shortening or even a pedicle excision to let the spinal cord have more room on the concavity, even for 70, 80, 90-degree curves when, you wouldn't think that has to happen. And when we look at the MRI, we find a very tight spinal cord at the apex. Number two, in adults, we just published that 40% of adults will have symptomatic or asymptomatic cervical disease when we do adult spinal deformity surgery. And 10% of those need cervical surgery before their thoracolumbar surgery. So Dan Rue and my cervical colleagues have gotten me in the habit of always including the cervical spine in my MRIs as well. And obviously, occasionally in adolescence, we'll find a syrinx or Chiari, right, malformation. So the bottom line is, I don't want to have any issues with patients postoperatively with not knowing about what their entire neural axis looks like. So I'm very aggressive with getting an MRI, because one patient having a catastrophe intra-op in my career is too many. That's the way I look at it. So I'm overly aggressive.
Thank you, Dr.
Second
Lenke.
question
Another question was the Lenke 5.
Right. As I mentioned to the previous question, Lenke 5 curves, I decide on L3 versus L4 based on the lower end vertebra, touch vertebra, and the supine image. And then I do symmetry about the apex. So if the apex is L1 and I'm stopping at L3, my UIV is T11. T11 to L3 is symmetry about the apex. And I showed one of those cases. If the apex is T12 L1 disc and I'm going to L3, then I'll do T10 to L3. T10, 11, 12, 3 levels above apex. L1, L2, L3, 3 levels below the apex. So I like always symmetry about the apex. That tends to give me the best correction and the best balance overall.
Thank you very much, Dr. Lenke. We need to go to the case, but first, Dr. Rafael González from Spain. Please, Dr. González.
Sí, buenos días.
Buenos días.
¿Se oye bien? Yo tenía varias preguntas para el doctor Lenke, algunas ya han sido respondidas. La primera que nos preocupa es, yo he visto una imagen muy bonita que ha presentado sobre la realineación en el plano sagital tras una cirugía de corrección de la escoliosis idiopática. ¿Utiliza el sistema de clasificación de Genevois, Kariman, y cuál es su estrategia a la hora de manejar el plano sagital? Una pregunta es, ¿intenta adaptar el plano sagital al teórico perfil de Rousseau que le correspondería al niño? Esa es una pregunta, y la otra, si quiere me responde a esta y hacemos otra después. Varón.
Sure. That's a great question. Obviously, the normative sagittal plane alignment is still, I think, very controversial. I do like the Rousseau system. I do pay attention to that in my adult surgery, especially when we're correcting the whole spine from upper thoracic spine to the pelvis. I think how we put all the instrumented spine we have control over. The problem in AIS, we don't have control over typically the whole spine, just the select region or regions that we're fixing. So as I think I've shown in several of my cases, my goal is to optimize the 3D alignment in the region we're fixing. If it's just a thoracic spine, then typically that's creating more thoracic kyphosis, derotating, and then obviously creating a straight coronal plane. And if it's a double major curve, as I showed, where we have a thoracolumbar kyphosis, then I want to push the thoracolumbar kyphosis ventral, create more thoracic kyphosis and a little more lumbar lordosis in the instrumented region. As far as trying to replicate Russell curve types, I don't do that in children because I don't control the whole spine down to the pelvis. You know, we rarely do, we never do fusion to the pelvis in AIS, right, in AIS patients. So I think the goal should be to optimize the three-dimensional alignment of the regions that we're treating. And I think long-term, we'll have to see if that produces the best spontaneous correction, as I highlighted in that one case where we had excellent cervical lordosis and lumbar lordosis production afterwards. You know, we don't always see that. Obviously, that was a case I highlighted that had dramatic improvement. But if you look carefully, you often see, especially in the neck, you see much better positioning if you create better kyphosis. And obviously, Peter Newton and others have shown better lumbar lordosis after better kyphosis production. So certainly, we're seeing trends that the better three-dimensional, especially thoracic correction we do, the better cervical and lumbar alignment we have long-term, which obviously has to be a benefit to the patient, right, long-term.
Thank you, Dr. Lenke. Dr. Armando Pineda from Venezuela, please, can you share us something?
Sí, gracias. Ya me contestó el doctor la pregunta que le hice sobre...
Okay, we're okay.
Le hice la pregunta sobre la resonancia magnética que...
Sí, muchas gracias.
Y ya me contestó.
Gracias, Dr. Pineda. Dr. Cristiano Meneses from Brazil. Cristiano.
Thanks, Baron. Dr. Lenke, sorry for not having my video. My video is locked since the beginning. I don't know, maybe some technical problems. My question for you is about some of your main tips for sagittal plane kyphosis correction. I mean, what do you think is the most important points to get that type of correction you showed us?
So I think it's both the carpentry, i.e. the Ponte osteotomies, as well as a very secure screw fixation at the apex. So we don't get pull out of those screws because there's a lot of force that we put on those apical concave pedicle screws. And the third component by far is this very stiff kyphotically contoured rod. So my technique is I put a sagittal plane bend only into my rod, a hyperkyphotic bend. Then I use reduction screws, or you can use reduction devices to pull the spine, posterior and medial to the stiff rod. The rod, no matter how stiff the rod is, it always gives in a bit. So the key to me is to go very slow. The slower you go, the more the spine comes up and the less the rod gives in. If you go very quickly, the rod straightens out, flattens out quickly. So you have to just take your time, 5, 10, 15 minutes of very slowly bringing the spine posteriorly and medially. That also gives the neural axis time. This is a spinal cord lengthening procedure. So I've had several circumstances where I've lost data doing posterior medial aggressive translation of AIS curves because you're lengthening the spinal cord both in the coronal plane and the sagittal plane. So that's another reason to go slow. But probably of all three of those, of the carpentry, the osteotomies, the screw purchase, or the rod stiffness, I would almost say the rod stiffness is most important. You have to use a very stiff rod because the rod, if you use a flexible rod, it's going to always give in. And you'll end up with a very flat concave rod. But again, all three are important, the osteotomies, the screw purchase, and the rod.
Okay,
thank you, Cristiano.
Great presentation, great explanation. Thank you.
Okay, but Baron, let's go to the case.
Yes, sure, Dr. Hani, thank you.
We have only left 10-15 minutes. I try to share. Okay, I have no related disclosures with this presentation. This is the X-ray of a student, 16-year-old girl, no medical problems, prominent right rib hump with a visible spinal curve and shoulder imbalance, as you see, with the left shoulder lower. We have a proximal cervical curve 54 degrees, 96 main thoracic, and 43 degrees lumbar. From T5 to T12, 49 degrees, and lumbar lordosis 54 degrees. Bending, we see that the upper cervical corrects to 46 degrees and very stiff, the main thoracic, and the lumbar corrects to 29 degrees. The pulmonary functional text, the vital capacity, there's some restrictions. It's greater than 50%, it's 55%. And as Dr. Lenke mentioned, I almost always, after my experience, to do a total MRI in order to not having any hidden or surprises. This is something very important to have it before surgery. It's normal in this case. And this is the photo of the patient. As you see that the hump, the lower left shoulder, and this is the patient. First question, how to classify this curve and what to do. Many questions. To go posterior only? Do you have combined instrumentation fusion, anterior release, multi-level selection of fusion levels? How? Lower instrumented vertebra? What type of instrumentation? What to do with the rib hump? It's very important for the patient. And how to correct.
How do you classify the curve?
Yeah.
For you, which kind of curve is?
Yeah. You know what curve?
No, it's a question for you.
For me, I know.
Do you classify or not?
Yes. You want to see it, but these are the questions: what to do, and classification. I think it's that we have 3 structural.
Right.
I mean, I don't know if Dr. Lenke agree with this.
Yeah, by what you've shown, absolutely. Obviously the major curve is thoracic, but both the proximal thoracic curve above and the lumbar curve below, side bend to greater than 25. So by definition, it's a type 4 curve. It's a 4A. The lumbar modifier is an A, and then it's a plus because there's a bit of maybe rotational kyphosis, but as you mentioned, T5 to T12 is a bit hyperkyphotic. So 4A plus, and then I would give it L2. So it's a 4A plus L2, since L2 is the lowest touched vertebra in the coronal plane.
Yeah, the concept of the touched vertebra, it is a new concept. Right. So you here, I agree with you here, the touched vertebra is L2. But
I had a question for Dr. Lenke about the classification, because it seems, in my point of view, seems like the upper thoracic curve is not symptomatic because the left shoulder is down. That is, do you taking care of this to classify the triple major?
I think the key is that anytime you get such a large, rigid main thoracic curve, the proximal thoracic curve is also going to be very, very rigid, right? Even more rigid sometimes. So even with a right shoulder high, I think, you still have to include that curve. You really don't start at T4, T5 on these curves. We almost always start at T2 or T3 with these very large main thoracic structural proximal thoracic curves, even when the right shoulder is high. Because if you get a lot of correction to the thoracic curve, you can throw the left shoulder high post-op. I've seen that, unfortunately, in my cases. So I'm very aggressive to control both the proximal thoracic and the main thoracic curve in these very large, rigid main thoracic scoliosis cases.
Okay. It makes a big difference if you stop at T2 or T3. Here in this case, maybe, it is not easy to decide. Right. Because if you want to correct the upper cervical, technically, if you correct it, you may lower down more, maybe, if you correct the kyphosis here. So it is not easy to, what do you think to stop, 3 or 2?
Yeah, honestly, I'm usually stopping at 2 on these cases, mainly because the pedicles of 2 are so much larger than 3 and 4 that you get really good screw purchase. So you can really control and you can then you can either distract or compress on the two screws to really afford better positioning of T2. You can and again, here's where as you get the concavity of the proximal thoracic curve, as there's often no pedicles or type C and D pedicles on the right-sided concave proximal thoracic spine at T3 and T4, T5. So it's very, very hard, pedicles to get good purchase on the right side here. So I just like T2 because I know I can get really good, strong pedicle screws at T2 bilaterally, and so I can control that area very well.
Yeah, but if you make some distraction here on the concave side, you are pushing down maybe the left. So better if we start here maybe on correcting the convex on the cervical.
Yeah, but what I've seen though, honey, I mean, on this curve, you need a lot of main thoracic correction. And as you start correcting that main thoracic curve,
you correct the left.
That automatically corrects the left shoulders, So much so that, again, I've ended up with the left shoulder high in these cases. That's very possible. I think you have to be, especially again, not in a smaller curve, but in this kind of curve, especially if you're going to be very aggressive, which I think you need to be three-dimensionally because of her cosmesis, right? Her clinical appearance is horrible. She needs a lot of correction on this curve.
What about provoking more kyphosis in the upper part of the instrumentation? Because if we correct this in the sagittal plane, if we correct it really, there's a risk of having a hyperkyphosis at this level.
That is correct. So my correction maneuver here is I instrument the left rod first, but I don't put any correction on the proximal thoracic region. My first correction of the proximal thoracic region is concave distraction with the right rod. So I will compress the left rod, but only after I distract on the right rod. So I don't put any correction on the left proximal rod, only in the main thoracic region of the left rod during my initial correction.
Okay. Oh, so what? Going back, you have to fuse from T2 or T3 till the touch vertebra.
Yeah, here's controversial. L2 or L3, I can tell you, it's very controversial. There's a little rotation to L2, slight, right? And L3 is a more stable base. Again, I think here in my hands, honestly, I would get a supine X-ray, and if L2 becomes more stable just on the supine image, where the center circle line falls between the pedicles, I would stop at L2. But if it's still just kind of touching the corner of L2, I probably would go to L3. But I think that's a bit controversial.
Okay.
I think the key is the touch vertebra doesn't tell you exactly where to stop, but it gives you a nice guideline to think about that area. Either L2 or L3 here, I think would probably be okay. And I think part of it is, how much correction you get. If you are able to get a lot of correction, then probably L2 will be okay, especially if she's skeletally immature. If this is skeletally immature, I would absolutely go to L3 in a skeletally immature patient.
Yeah. Any comment from the panel? Any comment on what the levels? Any anterior release here?
No, I'm agree with. I am not very agree about that is a type 4, but it's not important.
Well, if we follow the classification.
Yeah, that's the.
I'm agree. Okay, but I think that is, in my point of view, I am of course agree about Dr. Lenke that needs a very important dorsal thoracic correction with point osteotomy, whatever you want, and I try to do a fusion between T3 to L2. I think that I don't need to do an anterior release in this case.
You don't need anterior release. Okay. So, any more comment? Any further comment before to tell you what?
Other comment I make, honey, is that as you showed on the sideband, this is a very stiff curve, and also that if you look, I look at the rib configuration. Number one, the ribs are very thick in this patient, even though it's a female, very thick ribs and very high meta angle on those ribs, right? So there's a lot of three-dimensional deformity at the apex of this curve. So this is not going to be an easy correction. I think, I definitely would plan posterior only procedure with multi-level Ponte osteotomies, but you know, you got your work. This is not going to be something you just put a rod in and correct, and it's going to just come over very, very easily. I think there's going to be a lot of carpentry here and a lot of work to get this optimally corrected.
Yeah. Okay, we decided to go from, I mean, since many years now, only posterior. We did only posterior, and we decided to go from, I mean, it's very important also to have all neuromonitoring. This is mandatory. We did release at the apex, 2 above and 2 below the apex, wide release in a fashion way, and we from T3 to L3. It is not perfect, but
it's very good.
Very good.
Yeah, but, and without any rib resection.
Right.
Without any rib resection from, and you see the shoulders. I agree with Larry that the main correction, it is the big correction of the main thoracic. You correct the left shoulder. Yeah, and avoid destruction here, and you will have it. So this is the case. This is the thoracic, and this is the patient in the immediate post-op. Well, it is. I mean, not easy to correct.
Right.
Yeah.
That's what I mentioned. To me, the key here is the ribs, honey. The rib alignment is very structural. So
Very
it's hard
structural.
it's hard to get a perfect correction. You're not going to get a perfect three-dimensional correction on this curve.
But with time, I show you now. It's not perfect.
Much better, but much better, obviously.
It is much better.
And also the question is, you know, if you do an anterior release in here, you're going to get a bit more correction. But unfortunately, as our data showed a long time ago, you'll have worse PFTs. And so I don't think the trade-off is acceptable. I'd rather have slightly less correction and better pulmonary function if this were my daughter.
Yeah,
that's my personal preference.
We fully agree with you. I mean, it's only 40 degrees, 43 degrees. Is to correct 10 degrees more. It is not
worth it.
Yeah, and this is the patient still have asymmetry here, but it's acceptable.
Right, exactly.
Yeah, and
you're starting out with a very difficult problem, so you know we have to understand we can't make things completely normal.
And believe me that the shoulders are very important for the patients.
Yeah, exactly, right.
Very important for the patients. Okay, as promised, and this is the patient 2 years. You see?
Oh, excellent, outstanding.
I don't know. Yeah, maybe the memory.
That's great.
Okay, 2 years.
Fantastic.
Okay, as promised, I know that you are busy, Dr. Lenke. We, on behalf of the SILACO, the Board of Directors and Scientific Committee, really, we would like to thank you. I know that you are busy. Your help and contribution are highly appreciated by the Latin American societies, and looking forward to a future collaboration. Thank you very much. Keep safe and have a great weekend.
Great. Thanks to all my friends. Great to see everyone. Be safe.
Thank you very much. It was a
see you
pleasure
live
to
soon.
see you again, Larry. Really.
You too, guys.
Muchas gracias a todos. Muchas gracias.
Have a great weekend.
Gracias.
Have a great
Gracias a
weekend.
todos.